afternoon, everyone. It is a real pleasure to be back in Michigan, which is my home, and I feel a very close connection to both University of Michigan because a lot of my money went here because my son graduated from University of Michigan, but also I have so many colleagues and collaborators in the room, and so I'm so pleased to be back home. So let me start with disclaimers. I have no financial or other conflicts of interest to present today, and the statements that are made are mine and mine own. They're not the National Human Genome Research Institute. They're not the National Institutes of Health. They are not the Department of Health and Human Services. All right, so my talk is about the issues of equity in thinking about learning healthcare systems. And my talk is really focused on learning healthcare systems that are genomically enabled, okay? So my frame in my talk is about genomic-based learning healthcare systems. And there was a National Academy meeting and report that was published in 2015 that I want to just kind of put some attention on as a part of my talk that really talks about the potential of genomics and its integration in learning healthcare systems and how it can be beneficial with regards to improving health. And I would like to talk about that from the perspective of the issues of equity within our country and addressing health disparities. So we have a challenge. And the challenge is this, that the potential of learning healthcare, genomically based learning healthcare systems, benefiting issues of importance with regards to health equity and health disparities in our country will be problematic, in my opinion. And this is a quote from the National Academy report. Groups adversely affected by disparities could be among those that benefit most from a learning healthcare system. I don't necessarily agree with that statement, and I'm going to tell you why. So this is a page 27 of the report. This is the only page in the report. Now, I know there's several individuals in the room who were involved in the development of this report and the workshop, but this is it about the issue of health disparities and genomically enabled learning healthcare systems that's presented in the report. And it gives me some concern from the perspective of thinking about this kind of broader context of thinking about the field of genomics and thinking about equity and how we go about really addressing these issues. So my colleague and I have been thinking about this as I prepared for this talk and been thinking about this in a more broader context of how we think about health inequities in our country and genomics, and thinking about how can you enable a learning healthcare system to enhance health equity. What can we do from the perspective of genomics and the integration of genomics within a learning healthcare system? So starting to think about this from clinical decision supports and the integration of clinical decision support, you know, we need to ask questions. What does the current data suggest? And how can that be used to improve care? So what data do we currently have from the perspective of genomics that's been integrated in a clinical decision support, and how that can be important with regards to improving quality of care within populations? And then outcome evaluation. So actually we have what is in the system currently to ask these questions. Does use of genomic information improve health outcomes? And when and for whom? And I think that is an important question that we need to ask with regards to how genomics is integrated into the electronic healthcare record in thinking about learning healthcare systems. And then how can we take the information as we're learning it and modify it to make sure that there's clinical utility for all? So how does this new information change assumptions? What research is necessary to improve information utility? Because I think that we can move forward to enhance the utility of genomically enabled learning healthcare systems for all populations within our country and across the world. But we need to recognize the challenge and understand what the challenges that we're facing. And this work by Dr. Popejoy and Dr. Malia Fullerton is something, if you have not read it, I would strongly encourage you to read it, that was published recently in Nature. is taking a look at the genome-wide association studies that have been published. So these are federally supported studies that have been conducted where the data is now in the public domain for researchers to use to help in identifying gene variants around disease. And what has happened since 2009 when an original report was done by Carlos Bustamante and colleagues and Dr. Fullerton's report in 2016. So the change has not been that significant. The change in 2009, 96% of all genome-wide association studies in the public databases were of European ancestral populations, and in 2016, 81% of all the samples were from European populations. That's clearly increasing the diversity, but there are still some very significant challenges for our country related to that. So one of the challenges is that during the past 7 years, the proportion of samples used in the catalog, the GWAS studies, from participants who are not of European descent has increased fivefold, but yet nearly 78% of this growth is due to an increase in the number of samples from East Asia, from South Asia, and Southeast Asia. Okay? So there has been a change. There have been a number of countries in Asia that have incorporated their data into those databases. Together, individuals of African and Latin American ancestry, Hispanic people, Native or Indigenous people represent less than 4% of all the samples analyzed. Collectively, these are the most vulnerable and traditionally underserved populations. So what this says is there has been more ancestral diversity within the Genome-Wide Association database, but from the perspective of underserved populations in the United States, not so much. So why is this important? This is another recent paper that I just want to make reference to. The senior author is Isaac Kohani. And they looked at analysis with regards to misdiagnosis, with regards to gene variants in certain populations. And what they found was because of the lack of certain populations in the database, they weren't able to really ascertain whether certain individuals were actually at risk or not. And because we need more individuals from diverse ancestral populations of the world within the databases to be able to make sense of the information. So it was not able to give the proper information, to give the proper care for the patients that received their genetic test results. So we're dealing with the challenge that we should recognize that we clearly have genomic variation across the world with regards to individuals that has an impact on treatment. And particularly what I would like to focus on is this issue with regards to drug treatment and making decisions with regards to what's the best drug for an individual. Recognizing that each individual is who we should be caring for, but we clearly have population differences with regards to who may have a prevalence of a certain allele or not. And so how do we make sense out of this and how we make sure that we can use the process of a learning healthcare system and the integration of genomics to help us in able to provide the best treatment for each individual patient. So I just want to give a context here that, and I'll talk for a minute about the issue of race more broadly. I am not talking about race and ethnicity and racial and ethnic differences in drug treatment. What I am talking about is the difference in the variation based on ancestral population and understanding who are going to have certain side effects or who are going to benefit from certain drugs, and the need to do the studies to understand that. And so this paper identifies a number of studies with regards to drugs that were approved by the FDA that they have been now requested the companies to go back and do additional studies. And that's where I think a genomic-enabled learning healthcare system can be of great benefit, and the ability to do this research and to do this work on different populations. But we have to have the system set up. I just loved your talk. That if the structure and the system is not set up to do that, we will have the inability to make sure that it benefits everyone. So I'm going to take a minute and give one case study. Some of you I know are familiar with this case study, but I think it illustrates the issue of the potential that a genomic-enabled learning healthcare system can have on our populations, on the health of our country, but also give some context and reality to some of the treatment differences and the challenges that we have. So I'm sure that most of the people in the room are familiar with Plavix, which is a drug that's often used for various related heart diseases and a variety of ways. It's one of the most commonly prescribed drugs in the United States. And a story here is, I think, of importance in thinking about how we can integrate genomic information in learning healthcare systems to actually improve health of populations that may be underserved or left out. So the CYP219 gene, metabolism gene, has differences with regards to the ability to metabolize Plavix. And that becomes extremely important as we think about variation across the globe and individuals who have the G allele and the individuals who have the A allele. So people who have the G allele can metabolize Plavix pretty well, and it's not a problem. But if you have the A allele, it's more difficult to metabolize the drug. So two things here. One is you see that there are places across the world that have both the A and the G allele. So it's not just distinct to one population. However, though, there are some places in the world, because of populations and people mating and just information, where that allele is more prevalent. And so with regards to the A allele, it is much more prevalent in the Hawaiian Islands and in the Pacific Islander communities within the Pacific, okay? So, the state of Hawaii. Over 30% of the population of the state of Hawaii are Native Hawaiian or Pacific Islander, okay? Many of them have the allele that does not metabolize Plavix well, all right? This became an issue because of the challenges within the state with the state Medicaid system and payment of Plavix that the Attorney General for the state of Hawaii decided to file a lawsuit against the pharmaceutical companies making Plavix, asserting that the companies understood that certain populations did not metabolize this drug as well, and that a significant number of the citizens of the state of Hawaii could not metabolize the drug, and it was being marketed to them. And so this issue, because a certain percentage of the population, over 30% of the individuals could not metabolize this drug well, how can we make sure that they too benefit with regards to treatment with their heart disease? And whether just doing a genetic test and genotyping is the step that really needs to happen, which is not a very expensive genetic test, but a test that's not always done. So if we really had a genomically enabled healthcare systems in the state of Hawaii to help to identify the patients that may be at most risk of not being able to metabolize Plavix, could that provide some benefit and provide more equity with regards to how we use information to provide the best care for all patients and for all populations? So I want to come to the close of my talk and talk a little bit about this question of race and ethnicity and are important for the learning healthcare system. And really kind of following on the first talk this session, this concept of race and its meaning with regards to our health is something that is challenging. And some colleagues of mine and I wrote a piece that was published in the New England Journal of Medicine that argues that actually we think precision medicine will change how we use race in drug treatment, and that the potential of moving beyond race with regards to drug treatment in the future, but that we have three challenges that we have to address. First, we need to increase the inclusion of patients of diverse ancestry and genomics. This is the important message of my talk. Without the ancestral diversity in our research, in our work, and our analysis, we will not be able to do that. Second, control of rising drug costs. This is a huge issue that I think is going to have a significant challenge in precision medicine. And improve the ease and usefulness for implementing a precision medicine approach. I talked to 2 students at lunch, and I know they're going to help to do that as they integrate electronic healthcare records and bioinformatic information into drug and treatment of individuals. But today, it's not the easiest way to get that information and use it at the bedside in providing care. But I do want to say that race and ethnicity are important, as well as other social concepts, in how we integrate that data into electronic healthcare records in a quality way, and then ultimately into decision-making within a genomic-enabled learning healthcare system. So with that, thank you, and I look forward to the panel.